क्या स्टार्ट होगी? मुझे फोन कैसे अगर करना होगा तो मुझे फोन कर देंगे कि हमको इस माइक म्यूट किया तो स्पीकर भी म्यूट है एक्चुअली. सर आप उधर कहाँ है सर? तो ऐसी पूछ रहा है जैसे मैं यहाँ पे रहता हूँ. ये कॉर्बिन कॉलेज से है? हाँ कॉर्बिन कॉलेज है. कॉर्बिन के पीछे ओल्ड. अच्छा अच्छा सर. ये बहुत दूर है इसलिए पूछ रहा था. हम लोग
डॉक्टर गौरव.
यस सर.
यार माइक ऑफ कर दे सर के.
हाँ.
Sir, exact 1 o'clock will start, sir.
A very good afternoon to all. I am Dr. Sumit Kumar Pal, Associate Professor, Department of Public Dentistry, King George Medical University. On behalf of our department, I welcome our respected Dean Sir, Professor R.K. Singh Sir, all faculty members, esteemed speaker, Dr. Paradigims HR, all PG students and UG students. The topic of today's webinar is New Paradigm of Dental Caries. Dental caries is a disease which, once established, is irreversible, as we all know it is, and this is worldwide the most common dental disease. So I think this topic is going to be interesting for all. Without wasting much time, I request our respected Dean Sir to say a few words. Over to you, sir.
Can you hear me?
Sir, yes, sir. You're audible, sir.
Good afternoon to all present. On the auspicious occasion of Dentist Day of our fraternity, being a Dean, Faculty of Dental Sciences, KGMU, welcome you all present in this webinar. I appreciate the efforts and hard work put in the Department of Public Health Dentistry, KGMU, for organizing a webinar on new paradigm of dental caries under the dynamic leadership of our young energetic head, Professor Vinay Gupta, and his team members. It's a matter of great privilege for me to welcome our guest speaker, Dr. Priyadarshini HR, Professor, Research Head and Chairman of the Ethics Committee of SCGI University, Kuala Lumpur, Malaysia. She is a wonderful academician, and I am very sure that she will make you understand the topic much simpler way and will give you an opportunity to participate, to clear your confusions, misconceptions through this interaction. At the end, I would like to thank you all for being with us, for joining this webinar. Thank you very much.
Thank you, Dean sir. Now I request Dr. Vinay Kumar Gupta, he is head of the department in Public Health Industry, KGMU, to introduce the speaker.
Good afternoon, everyone. It is my proud privilege to introduce my friend, colleague, Professor Paradigims, a multifaceted academic personality, tirelessly work in KGMU University, give her opportunity to be a research head for health science and chairman of KGMU Ethical Committee, currently working as a professor at the Faculty of Dentistry, KGMU University, Malaysia. Dr. Priya holds a Master MDS and PhD in Public Dentistry, first rank in BDS from JSS Mysore, and first rank in MDS from GDC Bangalore, and gold medalist from Rajiv Gandhi University of Health and Science, India. He completed biostatistical course in Manipal University also. An academician and researcher, has published many papers in high impact journal, presented many award-winning papers at national and international conferences, has been a guest speaker at many symposium and webinars, has been a trainer, judge for many UG, PG level presentation, debate competition, has been a member of curriculum committee, examination committee, KGMU University Research Board. She has been member in various national and international professional associations. Her research interests include social determinants of health, oral health promotion, early childhood caries, dental education. Over to you, Dr. Priya. Want to listen to you. And this presentation, this webinar is live on YouTube also. So approximately more than like 200 people are already joined. So over to you, Dr. Priya.
Thank you very much, Dr. Vinay, for your very generous introduction of me. You had promised you will introduce me briefly, right? But I think, thank you so much for that. Very good afternoon and warm greetings to everyone from Malaysia. At the outset, I would like to thank Dr. R.K. Singh, sir, who is the Dean of the Faculty, Dr. Vinay, and all his organizing team members for having me invited here as a guest speaker. And I would say it's my proud privilege and pleasure to be associated with a prestigious institution like King George Medical University, Lucknow. So with this, let me just give me a minute. I will share my presentation first, and then we shall continue from there. Are you able to see my screen?
No. Yeah, it's coming. It's coming.
Coming, right?
Yeah, it has come. Yeah, please continue.
All right. So as Dr. Vinay introduced me, I'm Dr. Priyadarshini, currently working as professor at Faculty of Dentistry, KGMU University, Malaysia. And I just wanted to show you all the place where I work. This is a beautiful Greek architectural university building where I work, which is called as a KGMU University. And the university has achieved 5+ stars in QS ranking this year. And before we proceed, I would like to declare no conflict of interest associated with this presentation of any nature, either intellectual or financial. And finally, there's a short disclaimer that most of the information in this presentation is from standard websites and resources, and mostly present as opinion as well. So this should not be considered as a gold standard of dental practice. So with this short introduction, I shall now move on to the proper topic. My presentation will be presented under the following contents. First, I'll be briefly introducing you to dental caries. Definitely, I'm not going to bore you with all the theories and things like that. And then I'll be talking on the newer paradigms of caries causation, then the newer paradigms of caries management, certain skills required, because most of you are, UG students and PG students who are going to be the future dentists. And so, what kind of skills that you need to develop in order to tackle this disease in future. And finally, a brief conclusion about this topic. Okay, before we move on, I want all of you to take a close look at this picture and tell me what exactly you see here. You can type your answers. Hello, can you hear me?
Yeah, we are able to hear. We are able to hear.
All right. So now coming and taking a closer look at the picture I just showed you. Probably some of you looked at the picture and thought it were two old people. Some of you saw to the closer look and thought that it were two younger people in the slide, right? What I want to highlight with this is that it all depends on our perspective, how we see dental caries. Because perspective means the way we look at things, and this perspective matters a lot, depending, on our understanding of the disease, on our management, everywhere, perspective matters a lot. So I've just encircled the one with the blue, you can see a different image, and the one encircled with the black, you can see a different image. So perspective matters a lot. The same is true when it comes to dental caries. Now, if I ask you all a question, what type of disease is dental caries, or what do you think is dental caries? What are you going to answer? Now, I'm actually very interested to know what is running through all your minds. So I just want to have a short activity with all of you, if you don't mind. I just want to see, what is your perspective of dental caries? So what we're going to do is, those of you who are carrying your mobile phones with you, can you please go to Google and open mentimeter.com. Could you open it? Can you please enter the code that is given here? It will ask you for a code. Can you please enter the code? And as soon as you enter the code, there is a question which pops up. Could you see the question? Could you access it?
Yeah, we are giving. Yeah.
Could you access it?
Yeah, I can access.
Okay, just a second. Huh? Okay. If you see the screen, you will get to know what people are answering actually. And depending on how many people answer, the size of the answer keeps getting bigger and bigger. If more people, answer the same thing, the answer becomes bigger. All right. Yeah, people are joining and answering now. That's good. Okay, you're saying caries is multifactorial, caries is irreversible, caries is a wasting disease, caries is progressing. Yeah, any more to answer? Okay, see, the multifactorial is getting bigger and bigger. Probably another person answered it as multifactorial. Okay, new answers. Somebody said it's a non-communicable disease. All right. Okay, so how did you like this activity?
Very nice, really. We have to learn these things actually. Okay, right.
Okay.
Please continue.
Okay, by doing this, now I got a quick idea as to what each of you think about dental caries. Now I know how to take my presentation, in what direction I need to take my presentation. All right, so I'll start sharing my presentation again. Okay, so you all just did the quick survey. Now, some of you said caries is non-communicable, some of you said caries is progressing, some of you said it's irreversible, and majority of you said it is, multifactorial. So what exactly is dental caries, and are we right in what we think of dental caries? If you look at the definitions of dental caries, there has been a major shift in our thinking, our understanding of dental caries. Back in 1960, when the first definition of dental caries came, it said that caries is a microbial infectious disease, which is characterized by demineralization of the hard tissues of the teeth and destruction of organic content. I think all of you remember this because you would have marked this 101 times, for your exams, especially in public health dentistry. So this was the first definition of dental caries when the understanding of the disease was very limited because they said it's infectious disease. Now, my question to all of you is that if caries was only an infectious disease, why didn't we treat it with antibiotics? How do you treat other infectious diseases? You treat it through antibiotics, right? So why is that we don't treat caries just by giving some systemic antibiotics to the patients? Now, that's where there's a lack of complete understanding of the disease. But definitely over the years, the researchers have really worked hard and they have come to new concepts of caries. Way back in 2011, Federico introduced a new concept which said that dental caries is defined as a biofilm-mediated, sugar-driven multifactorial disease. Okay? At least different factors have come into picture here just from microorganisms. This was due to the understanding that microorganisms in the oral cavity require some scaffold where they can hang on to. And this is provided by the dental biofilm. And obviously, for them to survive, they need sugar. And that's how, there's a dynamic interaction between the two. And then there's a change in the pH in the biofilm. And that's how the caries is caused. Okay, this looks better than the 1960 definition because at least we have a few other factors coming into picture. But this is not it. Today, the concept of caries has changed from even few factors to a complete multifactorial disease. What are these multifactorial components involved in dental caries? We have a set of host factors, agent factors, and environmental factors. All of us know this. This is not new for us. But then the subcategories which have come into each of those is very elaborate in the present situation. There is a dimension of socio-economic component. There is a dimension of social component. There's a dimension of behavioral component. There's a dimension of lifestyle component, which have all come into play when we talk about dental caries. So in today's era, we can say that caries is just not an infectious disease. Caries is a multifactorial disease. And these multiple factors come from various determinants It could be environmental, it could be behavioral, it could be lifestyle related. Multiple factors have come together to cause dental caries. Now, my next question: if there are so many factors, then what is the role of microorganisms? So should we completely forget the role of microorganisms in dental caries and say that, that is obsolete, that is old? No, definitely not. We know that these factors are not the direct etiological factors. This is where we have to understand that there are certain etiological factors which are directly involved in the disease process, but the rest of the factors which are new relatively are mostly the risk factors which contribute for the chance of development of dental caries. So the basic understanding here should be how to differentiate between etiological factors and how to differentiate between risk factors. Risk factors are modifiable. There is no 100% guarantee that the risk factors will cause the disease, but definitely presence of risk factors will increase the chance of a person to get that particular disease. And another thing is that risk factors are modifiable. If you can identify these risk factors and eliminate them, you can completely avoid initiation of dental caries. So this is the beauty about the risk factors. So our understanding now is that there are two sets of factors. One factor is a definite etiological factors. Rest all factors are risk factors for dental caries. So now what we're going to talk is about the paradigm shift which has happened in caries causation. The word paradigm simply means a pattern of a disease or a model of something. Okay. So now there is a change in the pattern. There is a change in the model of this caries causation itself from an infectious disease to a multifactorial disease, from just identifying the etiological factors to moving towards prevention of risk factors. So this is the major paradigm shift which has happened. So if you ask me, now there are so many factors. Before, at least we could say that, these 4 factors or the etiological factors could cause caries development. Now with the listing of so many factors, if you ask me a question, who is at risk for caries? I will personally say everyone who has teeth is definitely at risk for caries. Maybe the grade or the severity of the risk may vary between person to person. Maybe some are at low risk, some are at moderate risk, and some are at high risk. But definitely everyone with teeth, is definitely at risk for developing dental caries. Another mistake, what we have always done and what we are still continuing to do. Now we, slightly know about the paradigm shift in the caries causation. But what are we doing as dentists? How are we managing this disease? Come on, be honest and tell me. Don't we wait for our patients to come back to clinics with wide cavities for us to fill it up? This is what we are going to look at, right? This is where we are going wrong. We are trying to diagnose the disease when it is already full blown and we can hardly do anything. And when it comes to patients also, have you seen anybody, coming with a very slight initial caries and saying that, doctor, I noticed a change on my teeth. Can you have a closer look at it and say whether it is caries? I don't think even 5% of our patients come with us with this initial stage of disease. Even they come when the cavity is quite big and where symptoms have already started in terms of pain and swelling and things like that. Only when it becomes unbearable, they rush to the dental clinic. See, again, this is the mistake we are doing, maybe because of our attitude or maybe because of our lack of understanding. We are all going wrong together, at this point of time. So what we have been trying to do here is that we are trying to only treat the symptoms, but we are not trying to treat the cause of the disease per se. Whereas our objective should be to go to the root cause of the disease and eradicate it completely. That is probably one of the reasons why caries is still the most common disease affecting adults. I read it somewhere, it says it is the 10th common disease affecting mankind. So I think this is one of the reasons why, caries is so prevalent among children and adults. Now, this requires a paradigm shift. It's not only in terms of understanding the etiology of caries, but in terms of understanding the caries management. So how are we going to understand the caries management henceforth? What is the paradigm shift that has happened in management of caries? It has moved from a curative aspect to a completely preventive aspect. So what do we understand by curative to preventive? Previously, as I said, patients came to us at the last stage of the disease. We didn't have an option. So what we did as dentists, we drilled a cavity and we filled the restoration. This was the only option left with us. But now the way we look at managing caries is going to go for a change completely. So how are we going to manage our patients in this era, so that caries can be completely controlled? As a famous saying goes, an ounce of prevention is worth a pound of cure. This is, every word of this proverb is so true that, prevention is any day better than cure. So now what we have to change in our system, in our attitude, in what we are practicing is that we have to incorporate elements of preventive dental care rather than completely base our practice on the curative care. What do you understand by preventive dental care? Preventive dental care means actively caring for one's teeth. What do you mean by actively caring? I'm stressing on the word active because actively means we are going to take the responsibility of taking care of our teeth. It is not just once in a while, but on a regular basis, we are going to take responsibility for our own health. So it includes actions taken by both the dentists as well as their patients, because it has to always work in combination. We cannot hold any one party responsible for this. Why do you think preventive dental care is very important for us? There are added benefits, to the preventive dental care. When you practice preventive care, the first thing what is going to happen is that any potential problem can be detected early. See, when it comes to threatening diseases like cancer and all, patients are so proactive in the sense, nowadays with the increasing awareness, especially in the cities, people go for, initial diagnosis, people go for regular checkups for tumor markers and other things just to make sure that they don't have any life-threatening disease. But when it comes to oral diseases, the attitude is not the same. That is the most neglected part of the health is, it's my personal opinion that, many of our patients, they have a total negligent attitude towards the oral health, probably because they consider oral diseases are not life-threatening. So when automatically this attitude changes, when patients come early for us for a routine checkup, we can identify any potential problems, including oral cancer, at a very, very early stage. So the same holds good even for dental caries. Dental caries can be detected at the first visual change, where we can treat it very minimally. So this is the first advantage of practicing preventive care. The second advantage is that treating it in a minimal invasive manner. I will talk about this in detail in the successive slides, but for your information, minimal invasive manner means that we're not going to interfere much with the healthy tooth structure. We are planning to conserve as much of tooth structure as possible. The third advantage will be cost effective. When you look at caries as a burden on the governments, when you have to treat a large number of people, definitely you will think, in terms of the outcome that we are going to get for the money we are going to spend. So if you talk about cost effectiveness, this kind of a preventive approach is highly cost effective. I can say 95 to 100% cost effective when we talk about, preventive dental care. And last but not the least, from the patient's perspective, it is cost saving. When patients come early to us, when the problem is not big, and when you solve it, very minimally, the cost per treatment for the patient also will come down. So these are the added benefits of, practicing preventive dental care as part of your routine dental practice. Now, who has to initiate this kind of a preventive dental care? As I told in the previous slide, it has to be an equal, shared responsibility between the patients and the dentist. Both have to understand that, they have to work in partnership. How patients can help dentists? Patient can take good care of their teeth at home, follow the instructions given by the dentist, come to a regular dental checkup. So this is we call it as a self-care, what patients can do from their side. And how dentists can help the patient to reduce the burden of this problem? Dentists can do a regular dental checkup, identify the problems early, and treat the conditions in a minimal invasive manner. So this is how both of them have to work in partnership. So if you look at the diagram, the central part, which is literally, very dark in color, is a maximum benefit where there is an equal shared responsibility between the patients and the dentist. I'm not sure whether you're aware of the new concept which is emerging in, patient treatment. Before, I remember still, when I did my UG and my PG as well, we had a standardized treatment plan. We used to, in fact, have the same order. This is phase 1 therapy, phase 2 therapy, phase 3 therapy. And we had standard set of procedures to be done for all the patients. It was almost like a fixed plan of treatment. But the concept has completely changed now. It has moved towards a patient-centered care from a dentist-centered care. In a dentist-centered care, dentist decides, what is required for the patient, and mostly it is like a generalized approach. In a patient-centered care, patient takes the autonomy, and most of the care is delivered in discussion with the patient. So this is more like a personalized care that is delivered to the patients. I'll give you a general example for you to understand it better. Now you decide to buy something new for you, maybe clothes or something. So you go to a shop and then you try out. Of course, you will get many sizes of the same type what you want. But many a times it so happens that that size may not exactly fit you. It may be slightly loose or slightly tight, It may not fit you correctly. But then if you take cloth and go to a tailor and, get it custom made, that fits you exactly. So this is difference between a generalized care and a custom made, tailor-made care for the patients. So the current concept globally is to deliver a patient-centered care than a dentist-centered care. So now, coming back to the preventive component in your dental practice, is it possible for us to now adopt this kind of a preventive practice at a professional level in our routine, dental practice? Is it possible for us? Okay, this is an interesting picture I found, and I thought, it would ignite some thoughts in your minds as well. That's why I've used it here. If you take a look at this picture, the face looks like a cat, okay, and the body looks like a parrot. So if I ask you, choose which animal is this or which bird is this, now you're definitely puzzled, isn't it? So you don't know whether to say there's a cat or a parrot, okay? If you ask me, I would give a new dimension to it altogether. I would say, since it's a combination of cat and parrot, I would start calling this creature as a carrot, okay? So, this is just on a lighter side. But what I'm trying to say here is that when you have, your curative side on one side, when you have to incorporate preventive dental practice on the other side, definitely, you will be puzzled that from where to start. Now, should we completely stop what we are practicing all this while? Should we adopt something completely new? Or how should we go? What should be the future? I'm not definitely asking you to stop what you're doing. I'm just asking you to modify what you're doing, okay? Because sometimes change is definitely good if it is for the betterment of the people. And definitely it's better to change our attitude and practice as well. We're not going to introduce anything new in our practice. What you're going to do is we're going to amend, we're going to modify whatever is existing to add a preventive component to make it as a part of routine dental practice. So I'm not completely asking you to stop cutting cavity and stop placing restorations. No, it is required for certain stage of caries, I agree. But what I'm asking you to start, thinking of something new that you can incorporate with minimum cost, without having to much invest into the existing services, and how to, deliver better preventive services to the people. So this is what I was trying to explain. So from now on, we are going to incorporate prevention and oral health promotion within our routine dental care. The next part of the presentation, I will be covering on how we can incorporate this kind of a preventive, care into the existing routine dental setup that we have. All right. See, from past few slides, I've been stressing on the word prevention, very, very frequently. As all of you know by now, that prevention is all the measures that one undertakes in order to prevent the development of a disease, right? Do you agree with me? Because you've been reading the prevention definition, from year 3, if I'm not wrong. So I think, we should all remember the definition of prevention. And we also know by now that there are 3 levels of prevention: the primary, the secondary, and the tertiary, applicable for different stage of the disease. What prevention I am stressing from the beginning of the presentation is mostly the primary prevention. See, secondary and tertiary prevention, somehow we are still doing as part of routine dental practice, maybe without our knowledge. We have already incorporated the components of secondary and tertiary prevention. How it is different from primary. the actions that we take after the disease has started is a secondary and the tertiary prevention. That's what we have been doing so far. Now, what I'm stressing you to do is to incorporate primary prevention, that is, the actions that we need to undertake before the disease has even initiated, where we can identify the risk factors and completely eliminate these risk factors. So how are we going to do it in a very systematic manner? Now, we are going to incorporate all the modern methods that we have with us, okay, which are not very expensive or which are not very complicated, that we cannot learn now. Definitely, these are very simple, and within limited time, I think all of us can learn and incorporate this into our dental practice. And most of you are still students, so you still have a very bright chance that you incorporate this from right now, because by the time you graduate, you're already competent enough, to practice this kind of a preventive care in your own setup. I would call them as skills, because these are some practical skills that is required for a dentist to incorporate these kind of a preventive components in your dental care. Now, I have divided these skills for your understanding into 4 major categories, okay? The first category is a skill for caries risk assessment. The second skill is for caries diagnosis and the stage at which we are going to identify the disease. The third component will be risk-based management, which will be limited to the particular tooth which is at risk for caries. And the fourth component is a risk-based management, which will be a holistic concept of managing the entire patient. So we are going to learn now all the techniques that we are going to do for a preventive dental care exclusively for dental caries in our routine care. Now, coming to the first one, that is the caries risk assessment. I'm sure all of you must have heard this word caries risk assessment. I don't know how much you understand the practical application and the benefits of this caries risk assessment. That's why I'm going to slightly touch upon, though I'm not going to go into the details of this caries risk assessment, all right? So in simple words, caries risk assessment means we are going to predict whether a person is going to develop dental caries in future. Now, you have a patient in your clinic. The patient has come for a routine dental checkup. Right now, the patient is free of dental caries, but that does not guarantee that the patient will be free of caries forever. So as dentists, we need to predict what are the chances of this person going to develop caries in future. So this is what we call it as a caries risk assessment. Though this prediction may not be 100% accurate, but definitely, it is going to give us a clue towards the chances of a person developing caries, considering certain existing factors. So how are we going to do this caries risk assessment? Do we have any tools with us, to do this kind of a caries risk assessment? Yes. You don't have to bother about developing a new tool because already there are a lot of tools available for this caries risk assessment. If you just Google it, you will get n number of tools. I have listed few standard tools here that is commonly used across the globe for caries risk assessment. And personally, I use CAMRA, which is caries management by risk assessment, because I feel it is very practical, can be done for a chair-side risk assessment as well, without having to invest into any new techniques or new equipment. The other caries risk assessment tools include Cariogram, the tools from the American Dental Association, the CAT tool, what we call it as a caries risk assessment tool by the American Association of Pediatric Dentists. So these are some of the standard tools used for caries risk assessment. So let me just share a sample of the caries risk assessment form. This risk assessment is of 2 types. One is for children below 5 years of age, and one is a common form for children 6 years and above, and even to the adults. This form looks something like that. There are a certain set of factors that you need to assess in your patient. Okay, this is a standard form. These factors are very widely variable, including the biological factors within the patient's oral cavity. They are the protective factors like the use of fluorides and things like that. And there are some disease indicators, and then there are some environmental factors as well. So when you assess it, it just takes 10 minutes time to assess these factors. All that you need to do is to ask the patient certain questions and tick whether yes or no. So once you've completed this form, actually, now you will have to count how many ticks are there in each category. Now, this is like, suppose there are 10 ticks in the high risk category. There are only 2 ticks in the low risk category. So obviously, this is weighing more. So you put the patient under high risk. Suppose, the number between the high risk and the low risk is almost equal. So you put the patient in the moderate risk category. So this is how we assess the patient's risk. Every patient who comes to the clinic, we maintain a record and then we assess the risk of the patient. So we now know that this patient is at a high risk for developing caries in future. Now, once we know the risk status of the patient, now the second thing what we have to do is we have to go and see if there is any caries in his mouth. That is what I call it as diagnosis of dental caries. And you may think that this is not new. All of us have been already doing diagnosing, dental caries in our clinic. But what I'm going to talk today is about a new type of diagnosis. It's not the one which you're going to use routinely in our clinic. Okay, this is the one which is non-invasive diagnosis, because with the changing paradigms, of the management of caries, we need to change the way we are going to look at caries, the stage at which we are going to identify the caries as well. So this is what is a diagnosis of caries. There's a very famous saying which says that current practice says that you don't need a sharp probe. All that you need is a sharp eye for caries diagnosis. See, previously we used to all use sharp explorers. We used to dig in the cavity, to feel the depth, to see whether it is a soft caries, a hard caries, and we used to meddle with the cavity like anything. Now, the modern concept says that you're going to completely stop doing that, okay? We don't want you to use sharp explorer when you are diagnosing. All that we want is a visual diagnosis of dental caries. You're going to just use your sharp eye to diagnose the dental caries. I got this beautiful slide courtesy my colleague, who has done a study on this, iatrogenic induced, cavitations. So she was, very generous enough to share this image with me when I told that I'll be giving a talk on caries, paradigms. This is a beautiful picture which shows that. So initially, the tooth was like this in the image one. And a dentist, by mistake, probed into it to see whether there is any softness or whether there is any cavity. These are microscopic images and then scanning electron microscope images. So once it was done, an image was taken. So if you look at the second image, see the cavitation that has been induced because of probing. Okay, this is the reason why, Extrand in 1987 had told that stop using sharp explorers for diagnosing dental caries. So then what are we going to use? First is eyes, okay? If at all you need to probe because of, the cavity is too minute, you cannot assess the depth of the cavity, or, you're not sure of whether the lesion is active or passive, please use a ball-ended probe, which is what we call it as a CPI probe, which has got a 0.5 millimeter ball end tip. Okay, so this flat end prevents any damage caused to the undermining enamel, and therefore you can prevent iatrogenic cavitations. There are some newer methods to detect dental caries which are totally non-invasive. Okay, one of them is the DiagnoDent, which uses laser-induced fluorescence. That is, the laser light. The red laser light is sent onto the tooth surface, and then the fluorescence that is reflected back is measured. Usually, there's a reading from 0 to 99, and anything which is higher indicates more demineralization. So here, there is no probing. It's just through laser light. Another new method to detect caries is quantitative light-induced fluorescence, in which, again, a different type of light is sent, and then it gives back as a blue-green fluorescence, and then it becomes very evident, because wherever you see blackish areas, that is the area of demineralization. Yet another new method of detecting caries is optical coherence tomography. Please take note, all this can be done on intact surface. This is to detect caries which looks apparently intact. Clinically there is no evidence of caries, but with this you can detect even the caries which is there within, where the surface is intact and there's a hidden caries below. Same in this optical coherence tomography as well. When the NIR light passes through the tooth surface and it receives, the readings back, it can be, interpreted in two ways. The first minimum interpretation is whether there is caries or no, depending on just the change in the color. And it also gives a digital reading as to what is the amount of demineralization that has happened. So this is another method of, new method of detecting caries. I know that, I will definitely not advise all of you to immediately follow all this from today itself, because these are relatively expensive. And I know that, at independent practices and even at institution levels, it may not be practically feasible to buy all this immediately. But I have an alternative solution for this. Clinically, without any of these equipments, how can you safely diagnose dental caries? This is through a new detection system of caries, which is called as International Caries Detection and Assessment System, what we call it as the ICDAS. I'm not sure whether you've heard of ICDAS. You might have, at least the postgraduate students might have heard about ICDAS. So this is relatively new detection of caries, okay, which is a part of ICCMS. ICCMS is International Caries Classification and Management System. So as part of that, this ICDAS is in existence. Most of the places in the globe, including Malaysia, now we are using this ICDAS for caries diagnosis, and we have stopped using DMFT. Now, what is the advantage of ICDAS? Or, okay, let me briefly tell you what is this ICDAS. Now, ICDAS actually gives a different code for different stage of caries. All that you need is just a visual inspection, under sufficient light, and maximum CPI probe wherever you feel that you need to probe. These are the only two things you require to clinically detect the stage of the caries lesion. And you need to air dry each and every tooth for 5 seconds when you're performing examination for detection. This is the only requirement for ICDAS. So ICDAS actually has codes from 0 to 6. Okay, definitely I will not go into the details of this, because this itself requires an entire session if I take a class on ICDAS. But that's why I'll just touch briefly on this. 0 means no caries on visual inspection. 1 means when you air dry the surface, you can see a slight visual change in the form of a demineralization, which is slightly whitish in color or brownish in color. Okay, and this is visible only upon air drying. Normally, as such, it is not visible. So this is 1. If you see a lesion which is brownish or which has got a slight discoloration, as it is even in wet conditions in the presence of saliva, that is ICDAS 2. If you detect a small cavity, what we say is a micro cavity or a small mini cavity in enamel, it is ICDAS 3. Sometimes you can see that there is an underlying shadow from the dentin. That means the caries has already reached DEJ, that is ICDAS 4. And ICDAS 5 and 6 are relatively easy to diagnose. This is because they are open cavities. The caries has already reached dentin. You can clearly see the dentin below. But the difference between 5 and 6 is that 5 is a small cavity covering less than 50% of the tooth surface, whereas 6 is an extensive caries which covers more than 50% of the tooth surface. I've got closer pictures for you to have a look. So this is how it looks. So ICDAS 1 is only on air drying, where on the fissure you can see that there's a slight change in the color in the form of demineralization, which is slightly brownish in color. Now, the second picture is ICDAS 2, which as it is visible that it is, the enamel looks slightly different from the surrounding enamel. It can be brown or it can be opaque. Now, just concentrate on the circle areas. Now, there's a small micro cavity in enamel. That means the enamel integrity has already been lost. So this is already reached a small stage of cavitation. This is ICDAS 3. You can see that there's underlying shadow with or without cavitation. From the, this is not an extrinsic stain or anything. This is from below. This is a reflection of the dentinal shadow. So this is ICDAS 4. And 5 and 6 are relatively easy, as I told you, because these are already open cavities, which is, visually very striking when you see in patients now. So all this while, mostly we have been concentrating only 5 and 6. But the newer paradigm of dental caries management says that you start focusing from ICDAS 1 when the patient comes for a routine dental care. That's the only way where we can try to remineralize, whatever damage has happened to the tooth without letting the cavity to form. Why is that we have stopped using DMFT? I just want to give you a rational justification that we know that DMFT identifies a caries only at the cavitation level, and whatever is below cavitation level is considered a sound tooth structure. So in a way, all of us are actually underestimating the caries in an individual. And DMFT, there is no concept of remineralization because you're just diagnosing caries at a cavitation level where the cavity is already formed. Cavitated lesion, you cannot remineralize or you cannot repair it completely. You have to remove the disease and then you have to restore it with a filling material. And also, you cannot track the progression or the regression of the caries when it comes to DMFT. Suppose you have a patient today, okay? The patient has come with a cavitation. You have done the treatment. You have done a restoration. You will recall the patient after 3 months. Now, how will you track the progress? How can you see whether the caries is progressing under the restoration or the caries has completely stopped because you have placed restoration? We don't have a monitoring mechanism when we're using dental caries diagnosis using DMFT. But just the opposite with ICIDAS. ICIDAS detects very early lesions. ICIDAS gives you an opportunity to remineralize, and reverse the caries lesion. And ICIDAS treats the teeth very minimally. And the major advantage of ICIDAS is you can track them or monitor the progression and regression of the caries lesions. So these are the basic advantages of the ICIDAS. Now, generally, we follow a charting like this. We have a ready-made chart for ICIDAS for all the teeth like this. And I've just shown an example. How are we going to score for ICIDAS? As I told you, you need to be familiar with the codes first. And then we know that, on the buccal surface, now I can see, after air drying, I can see a slight visual change here. So this is going to be ICIDAS 1. So I'm going to mark ICIDAS 1 on my chart. And then on the mesial surface, I can see that, there is a striking discoloration here, which is ICIDAS 2. And on the occlusal surface, we have an amalgam restoration, which looks intact without any secondary caries. So I would just give a code of 4, 0. 4 means amalgam restoration and 0 means no caries. This is as per the code of ICIDAS. Now, every time the patient visits us, we're going to keep a chart like this. This chart not only helps to record what is there in patient's mouth, but also to plan treatment for each surface of the tooth, what preventive measures need to be taken and what curative measures need to be taken. And every time there's a recall of the patient after 3 or 6 months, we're going to refer back to this chart and see whether what treatment we have done is successful or no. See, you can say that, I applied fluoride in my last visit. Has it healed? Has it remineralized? Let me check. Now I know whether the ICIDAS has gone back to ICIDAS 0 or ICIDAS has progressed to ICIDAS 2. So this is how I can track the progression of the lesion when I'm using this ICIDAS. Now that we have, come to the diagnosis, a new concept of diagnosis, we definitely have to adopt a newer management methods, not just drilling holes every time and, restoring it with restorative materials. Many places, they say that Dr. G.V. Black's principles of cavity preparation is considered as history because we're not going to practice it anymore. Due respect to him, I'm not saying, this is a waste method. My intention is not that. What I mean to say is that our understanding of the disease process has changed. There are new ways of diagnosing dental caries in a very, very initial stage. We have advanced restorative materials which do not require any kind of mechanical preparation for retention like amalgam. They're all chemically adherent to the teeth. So because of this, rationale, we don't need to use these principles of Dr. G.V. Black's anymore when we are, managing cavitated lesions. So now we have completed, the skills for the risk assessment and skills for caries diagnosis. Let us move on and see that how can we manage in a new way the tooth level risk for a particular tooth. All right. When I say tooth level, as I told you, see in ICIDAS charting, you will clearly come to know that which all teeth require attention. All right. You know that there are certain lesions which are very initial, just the change in the surface of the enamel without any cavitation. So those kind of lesions, what we call it as ICIDAS 1 and 2, where we say it is a very early stage, can be successfully managed depending on whether it is on the smooth surface or on the occlusal surface with the use of topical fluorides and also with the use of pit and fissure sealants. This is a new paradigm where we are trying to reverse and remineralize the enamel surface instead of cutting a cavity. As soon as you see a black spot, please don't go and cut a cavity, okay? We can try to reverse the disease process and remineralize the surface. Now, if you diagnose 3 and 4, that is small cavities, sometimes in enamel, and 4, of course, at the DHA, again, we are not going to use conventional, methods. We are not going to cut a full cavity, extend, and spoil healthy tooth structure. We are going to use a preventive resin restoration. I will be explaining later, and a minimum intervention restoration procedure in which we're going to manage exactly the spot where there is caries. We are not going to increase the width of the cavity anywhere other than where exactly the caries is. Okay, so this is another concept of managing small cavitated lesions. Now, when you have diagnosed extensive caries in the form of ICERAS 5 and 6, again, we're not going to go back and use conventional preparations. What we're going to use are only conservative preparations, managing just in and around the lesion only. We are not going to touch any form of healthy tooth structure. So this is the tooth level management. Now, giving you a brief insight on the topical fluorides, I'm sure theoretically all of you would have learned enough about topical fluorides. But when you go back to the literature and check that the most effective topical fluorides are, a lot of systematic reviews. There is one Cochrane systematic review also, on different topical fluoride applications, which says that the most effective in-office form of fluoride, which you can deliver to your patients, is 5% sodium fluoride varnish. Okay, this you could successfully use for spot application. Okay, not that it is contraindicated for a full mouth application, but considering the resources and the need, okay, this is very effective for a spot application. What do you mean by spot application? Whenever you see some spots of demineralization, just go and apply this, fluoride at only those spots. They will remineralize. Another important type of fluoride is stannous fluoride or gel solution. You can use whichever form. And stannous fluoride is mostly indicated for rampant caries and in children where there is extensive early childhood caries, where you want the immediate control of the caries mechanism. And the most recent, there's a lot of literature, if you find, is a silver diamond fluoride. Now, there are many studies from India as well using the silver diamond fluoride for arresting caries. It could be used for primary prevention, but its most application is seen in arresting even a cavitated dental caries. Studies have shown that it is very effective even in arresting a cavitated dental caries. So I think you all should explore, as students, as postgraduate students who will be doing research now towards their dissertation, you should all, explore these new preventive avenues for your study. Now, this is a case which we did in our own faculty. There was a 5-year-old, child with very, uncooperative in the sense that with a lot of, sugary habits, in the sense of consuming too many candies, and pampered child, consuming too many sugary drinks and things like that. When we saw the child, in a preventive clinic, we noticed that with active caries, the first image, if you see where there are arrows pointing, these are active areas of demineralization. That means the caries is very active. So what we did, considering the age of the child and also that, the child was not very cooperative, though it was required for a full mouth application of fluoride, the first appointment, we did not go for a full mouth application of fluoride. We just, went for a spot application of fluoride varnish because that the newer fluoride varnish, there is no problem with moisture control, very suitable for uncooperative children. Even if you don't isolate, they won't, because the fluoride varnish starts setting when it comes in contact with saliva. So moisture control is not a problem at all in case of uncooperative children as well. So we applied this. Since the caries was very active, we recalled the child within 1 month, for a review. We wanted to see whether the caries is progressing or there's a halt. We noticed that, the white opacities were slightly coming down, because we had taken photographs and things like that. So we compared. We saw that the caries was reversing, and, there was a control of caries with new areas of demineralization. So within 3 months, we called the child again for a second application of, fluoride. And again, we did the same procedure. We applied fluoride varnish. After 6 months, I came for a follow-up. You can see the last picture. This is what the end result is. You can see that all the white demineralized areas has already vanished. What the brown spots you see is already the arrested caries. The caries progression has already been halted. So this is how we manage this case with fluoride varnish application without any invasive procedure, within just 2 applications of this fluoride varnish. Another important, preventive agent I can say for the occlusal pits and fissures is pit and fissure sealants. I do not know, if you've already been doing pit and fissure sealants, maybe as a part of your exercise or something. But these days, pit and fissure sealants are being widely used worldwide because of their effectiveness. Again, a Cochrane systematic review on sealants by Ohovio shows that, it is effective to up to 60% in reducing or decreasing dental caries in permanent teeth. So, as all of you know that this one, the sealants are resinous materials. You just need to, there's no invasiveness in terms of cavity cutting or anything. For example, if you see a fissure which is discolored, if you know that there is active caries, you don't have to cut, you don't have to use your burr at all. Just isolate and then, etch the surface, wash, and then put the sealant and cure it. So what this sealant barrier, it goes, it hardens there, and it forms like a mechanical barrier. So once the mechanical barrier is formed, whichever bacteria which is trapped under the sealant, they are cut off from the oral environment. They don't get the supply of carbohydrates, and therefore they do not produce acids, and eventually they die. So this is how it prevents the progression of the dental caries. You can use a combination of pit and fissure sealants and fluorides. Like for a high-risk patient, you do the pit and fissure sealants, and then you apply a layer of fluorides on top of the sealants for double benefit. Who are the ideal patients for sealant? See, there's no contraindication to apply sealants at any age, okay? But only thing is, the sealants are most beneficial and effective in case of newly erupted permanent teeth. This is because in a newly erupted teeth, the cuspal tips are very sharp. Therefore, the fissures in the center look to be very deep, which are more prone for food accumulation and dental caries causation. So, when you do the caries risk assessment in young individuals, if you find them to be at moderate or high risk for caries, definitely, even though there is no caries, if you just find a new or a deep pit and fissure on the molars, you can just go and seal them to be safe in future. And definitely when you see initial caries like Isidas 1 and 2 in permanent teeth or in deciduous teeth, you can close your eyes and apply pit and fissure sealants on such teeth. This is a quick look at the procedure. As I told you, I'm not going to go into the details of the procedure. So when you see Isidas 1 or 2, you don't have to use any burr or anything. You just have to use a etching on it. Etchant is nothing but a 37% orthophosphoric acid. You just have to use it for about 30 seconds or 35 seconds and then wash it with a running water. Then dry the tooth thoroughly. Etching is basically done to create some kind of a microporosities on the enamel that will hold the resinous material. So then you apply the pit and fissure sealant, and because these are light cured, you have to use a light source and cure it for 20 seconds. So this is all. It's a very quick procedure. It does not take more than 10 minutes. But its benefits are, extensive. Now, moving on to minimum intervention dentistry, this is another relatively new concept in dentistry. Minimum intervention dentistry says that you have to minimally, invade the tooth structure. Don't go on cutting the healthy tooth structure. Just meddle with the disease part only. Suppose you see a dental caries, use the burr only where there is dental caries to excavate all the soft caries. The hard dentin you can leave behind, okay? You don't have to touch because it has got a potential for remineralization. And do not extend the cavity just to accommodate a restorative material because very new restorative materials are available which can chemically adhere to the tooth, like the GIC, the composites and all, which do not require any extra mechanical preparation to hold a restorative material. And it also works on the principle of risk identification and focusing on early prevention and disease management. So the minimum intervention dentistry basically works on 4 core principles of recognition, reduction, regeneration, and repair. So it says that try to diagnose the disease early. If you're not able to do, at least try to reduce the risk of a person. If you're not able to do that, what I mean is the caries has progressed further, try to regenerate, at least use some regenerative materials like fluoride or something and try to reverse this initial lesion. If still it has gone beyond your control, then only think of repair, which you have to be very conservative when you're repairing the tooth structure. Now, this is an example how we manage caries today and how it was managed using a conventional restoration in the past. The first picture you see is a preventive resin restoration. See, the yellow dot you can see on the tooth is the spot where the caries is. In the second picture, how you would have managed it conventionally, you would have started cutting a cavity, extending the cavity to the full length of the fissure, going to the typical design of blacks, including all the taper, inverse taper, everything, and make a nice cavity with nice floor and everything, removing a lot of healthy tooth structure. All right. But how we are going to manage now? We are going to just, pinpoint restorations, like we're just going to use a round burr and go in the area only where there is only where there is Hello, can you hear me?
Yeah, here actually somebody has joined and he has unmuted.
All right.
Please continue.
Okay. Yes. So we're going to just take a round burr and we're going to just, make a hole where exactly the caries is. We're not going to extend it anymore. So you can see that circle, that is a restoration. That is a small flowable composite where what we have placed there. And the remaining surrounding area, which is wider, is what we have done is we have sealed the remaining fissure using pit and fissure sealant. So this is how very conservatively we have managed the active caries as well as the surrounding fissures from developing future caries. Now, the whole idea of minimum intervention dentistry is to avoid something called as repetitive restorative cycle. I'm sure all of you must have learned it in your conservative dentistry. What happens when the patient comes to you with a caries? If your assessment of the stage of the caries is wrong, and if your thinking is wrong, for every small cavity, you go on cutting, for every small caries lesion, you go on cutting a cavity into a big one and place restorative material like an amalgam. And if you don't do a proper restoration, there may be, marginal leakage and secondary caries within 2 to 4 years. So the patient will come back to you again, and then you're going to remove that, and then again remove all the secondary caries. Shape the cavity to receive new restorative material. You're going to be removing some more tooth structure. So again, you place a restoration. After some years, the tooth has already become weak because you've removed a lot of structure. The tooth just gives away. Either it will, if there's further caries, it will go for a root canal treatment, or sometimes the tooth might just crack because a large restoration has been placed. So this is called as a repetitive restorative cycle. And this was very much possible with the conventional restorations. In order to avoid this repetitive restorative cycle, we have, adopted now the concepts of minimum intervention dentistry. Now, the final part of the presentation, where we're going to talk about the risk-based management. So just a quick recap, we finished with caries risk assessment, then we finished with identifying the caries in a minimally invasive manner. Then we learned how are we going to manage a particular tooth, with an initial caries or with a cavitated caries in a minimum intervention dentistry principle way. And then lastly, this is a very new concept, which is called as patient level management. Before, what you used to do, I have done it personally in my own, student days. Once I'm allotted a case for a filling, I just do that filling and I say that my work is done. I've done a good restoration on my patient. Okay, I will take up the next case. But currently, we are not teaching our students this, and we are also not practicing this because there's a new concept of patient management which has come into picture. Now you have managed the tooth. That means you know that the patient has already developed caries. That means that there are some factors in his vicinity, in his own oral cavity, or because of his own behavior, because of which he might develop more caries on other teeth in future. So we are not going to stop at treating only that particular tooth. We're going to go ahead and, we're going to see how we can manage this patient. Now, how we will know what component needs to be used in which patient. Now, this is where your caries risk assessment comes into picture. Now, if you have done with your treatment, go back to your caries risk assessment form to just have a quick look and see what are the factors in this particular patient which are causing the risk, because the risk factors are not same in all the patients. In some patients, the diet may be a risk because they may be consuming too many sugary items. In some patients, plaque may be the risk because they may not be cleaning their oral cavity properly. In some patients, lack of use of fluoride may be a risk because there are no protective factors left with them. So in some patients, there could be any systemic condition like hyposalivation or something. In some patients, it could be a neglected attitude towards health behavior, that they're not visiting their dentist regularly. So each patient has his own set of risk factors. And as dentists, it is very, very crucial for us to identify what is the risk factor in a particular patient. So when you have identified this risk factor to Caries risk assessment, now we have to engage our patients to reduce these risk factors. Otherwise, these are the same risk factors which are going to cause Caries in future. So you should have a talk with the patient, and then we have to do a patient level management. So we'll just go and quickly see how we are going to address individual risk. When it comes to dietary analysis, we know that diet and nutrition play an important role in health and disease, not only in the general health, but also when it comes to oral health. More than nutrition, okay, diet plays an important role when it comes to oral diseases, especially dental caries. We say that it's a local disease, a diet-related disease, because the food is going to come in direct contact with the teeth. Especially if there is a snacking habit with a frequent sugar consumption, this risk is going to go up. So as dentists, we need to identify this risk in patients who are frequent consumers of extrinsic sugars. When I say sugars, I don't involve all types of sugars. The intrinsic sugars, like, the fruits, where the sugar is naturally present within the fruit, may not be so cariogenic as compared to an added sugar, like you're adding sucrose to your coffee and tea, that may be more cariogenic. So we have to identify the sources of extrinsic sugar, the frequency of intake, and we need to definitely guide the patients towards improving this behavior. So how are we going to do it? There are different models for doing dietary analysis and counseling on our patients. A very popular one is the one given by the Eaton, and his colleagues with 5 A's approach. This model says that you have to first address the agenda with your patient, then assess the patient's diet, advise the patient, assist in preparing goals, and then arrange frequent follow-up. At this particular point of time, I would like to tell you one thing, that as dentists, we are definitely not qualified enough to entirely modify the diets of our patient. All that we can do is identify who is at risk, who needs modification, give them some general advice, and refer them to qualified personnel like the nutritionist. We are not independently making any decisions, but we will take the patient till the stage of identification and arranging for follow-up. This is all our role in dietary analysis, because dietary analysis requires careful assessment of other components of diet which may have a bearing on the general health of the patient as well. So we cannot just see it one-sided only from the oral point of view and modify the diet of the patient. So, but we can be useful in identifying such patients, in giving them general advice, and also arranging for follow-up with nutritionists. You could use variety of forms. This is a sample form what we have developed here. Okay, this is a systematic collection of information about diet from the patients. So when the patients visit us, what we do is, for every patient we give this form. We ask the patients to fill up the first part of this form, which is a 24 hours diet recall. We ask the patient to enter the date, that is the previous 24 hours, the time, the item consumed, the quantity. For example, if the patient has tea in the morning at 6:30, the patient has to write 6:30 a.m., 1 cup tea with 2 spoons of sugar. So we ask the patients to enter all the details of diet. Once this has been done, we carefully go through the chart, and then we do a second assessment where we ask the patient on a routine basis, what are the different categories of the food that the patient consumes, and we're going to develop a score based on the required dietary allowance. So we're going to compare it to the standard chart and see whether the patient's dietary requirements are adequate or inadequate. Another component to this is a sugar component. We also have another component, which is, we're going to assess the frequency and the type of sugar that the patient is going to consume every day, and allot scores to the patient and see whether the patient's habits are excellent, whether the patient's sugar habits are bad, good, or what needs to be done. So once we have completely assessed the patients like this, okay, the second step is that we are going to touch only on the dietary sugars and not on the other aspects of diet, and give some general advice to the patients. You should be concentrating more on avoiding extrinsic sugars if possible, completely avoid extrinsic sugars if possible. Reduce the frequency of sugar intake. Don't keep eating every now and then, because the more number of times you eat, the more number of times there is a drop in the pH in the oral cavity, and then there is more demineralization. Avoid exposure to sugars in between meals. You're not supposed to eat sugary items in between two meals. What is the rationale behind this? If you eat sugary items with the meals, because you're already eating your meal, there is enough saliva in your mouth to clear off the sugar immediately. So in between meals, taking sugar is harmful. We're going to advise on healthy snacking. There are alternatives to snacking. There are certain people who snack like anything, with all these sugary filled items. So you can always suggest them healthy alternatives like snacking on fruits, snacking on nuts, snacking on something like cheese or something. So we can always suggest alternatives to the patients. And lastly, but most important, every patient has to try to brush the teeth after every consumption of sugar in the form of liquid or solid. But I know that practically it may not be possible for many of us. We cannot carry toothbrushes wherever we go. So at least rinsing mouth after drinking or eating sweets is mandatory. So these are some of the areas that we need to concentrate when we are talking to our patients. The rest, of course, if you find that the dietary requirement of the patient is very inadequate, you please refer the patient to a nutritionist who will take care of the other aspects of the diet. As dentists, we are concentrating more on the sugar aspects of the patients. Some patients may come back to you with a risk of plaque. You may see a lot of plaque in their oral cavity. So as dentists, what we can do is, we can use plaque disclosing agent, maintain a plaque record, okay, and find out the attitudes from the patient on maintenance of oral hygiene. We can do a scaling and polishing and then track patients' compliance. And then during the follow-up, we can always, repeat the plaque monitoring and see whether the patients are following instructions or patients are being compliant to our instructions or not. A third important component, when we're talking, is to encourage patients to use fluorides. So you need to take extra time after your treatment. You need to talk to patients at least for 15 minutes, regarding all this. If you find the risk, is from lack of fluorides, we have to encourage all patients to use fluoridated dentifrice. You can advise it for both children as well as for adults. Children as young as 2 years can start brushing with fluoridated paste. Only thing is that we have two formulations, around 1000 to 1500 ppm of fluoride containing paste for the adults, and for children probably around 500 to 700 ppm of fluoridated toothpaste can be used. If you're using for very young children like 2-year-old, we just have to use a smear of toothbrush, very little. 2 to 6 years, you can use a small rice grain, as size of a single grain of rice of fluoridated toothpaste. And above 6 years of age, you can use the size of a pea, okay, for the children. Adults can use fluoridated toothpaste, and then everybody has to at least brush twice a day. And, depending on the risk, sometimes you may see a lot of white spot lesions, which are initial caries in patient's mouth. So you already know that the caries is already in its initial stage. For such patients, whom we call it as high-risk patients, definitely you have to prescribe for a fluoride-containing mouth rinse, either on a daily or a weekly mouth rinsing basis, okay? A note of precaution here, we are not going to generally prescribe fluoridated mouth rinse for children below 6 years of age, because the manual dexterity wouldn't have developed completely, and there will be chances that these children swallow all the mouth rinse. So we don't want that to happen. So below 6 years of age, we are not recommending any mouth rinse. A newer concept again is using or substituting normal sugars with sugar substitutes. Now, if you go in the market, there are a lot of candies and chewing gums which have come with the sugar substitutes, most commonly the xylitol or sorbitol, you can see. And xylitol is very, very important for caries prevention because it is anti-cariogenic. It has got a mechanism to disrupt plaque, and also it stimulates salivary flow. So because of all this mechanism of action, xylitol is considered to be an important sugar substitute where you can replace sugars, normal sugars with, substitutes. So some children, if you find them frequently snacking with these candies and all, you can always advise the patients to replace these candies with the ones containing the sugar substitutes. Then coming to oral health education, and we should never miss as dentists, as dental educators, health educators, we should never miss giving oral health education to the patients. Half of the reasons why there's so much of prevalence of the disease is because of ignorance and lack of awareness on the patient side about the disease process and how to prevent it and how to take care of it. Probably with your education, at least 10% of your patients will surely change their attitude and, start following healthy habits. So we should never miss, oral health education sessions with our patients. And these sessions can be made more effective by visual treat for them in the form of toothbrushing models or flip charts or videos. You should always use a health education aid when you're giving oral health education. And then you may think, what is there in just advising patients correct brushing technique? But a correct brushing technique can actually do a great deal of difference in the oral hygiene of the patients. We know that plaque is one of the main causes of dental caries, and cariogenic plaque especially is the most important culprit for initiating dental caries. So if patients learn to keep their mouth clean, disrupting all the plaque, I think there is no initiation of caries at all. This is something what patients can definitely do from their side. All that we need to do is just correct their existing habits and lead them to correct way of oral hygiene maintenance. I would like to stress on one thing here, that there should be an essential knowledge among all the dental students about all the brushing techniques. It's not only for theoretical purpose, because as I told you, the care is personalized. Each patient may require a different kind of brushing technique. For normal, healthy individuals, young adults, we may go for modified Bass technique. Patients with periodontitis require a modified Charters technique or a Stillman's technique. Patients with orthodontic require a Charters technique. Children may require a Phone's technique. So we should be in a situation, we should have the skill to demonstrate different brushing techniques depending on the needs of the patient. And not to forget, we are in the era of, using a lot of interdental aids. Previously, the concept was that only few patients were recommended these interdental aids, especially by periodontists, wherein they found that there was a lot of gingival recession or there was too much of interdental space and things like that. But no, interdental cleaning has become a part of oral hygiene instructions currently, because the toothbrushes cannot clean interdentally, and therefore you need to clean your interdental areas. So the patients need to clean interdental areas using a proper interdental aid. So you can prescribe dental floss, and you can also prescribe, unituft or multi-tuft interdental toothbrushes, depending on what the patient requires, depending on how much of place is there interdentally, and depending on the age of the patient and what exactly the patient requires. So you should also have the skill for demonstration of different interdental aids. So we have almost come to the end of this presentation. Now I would like to summarize the whole presentation in just one slide. So today we just saw that, the paradigm, there has been a paradigm shift in understanding of the caries causation and the management of caries as well. As we understand the new paradigms of caries management, it is high time as dentists, we adapt to newer paradigms of dental caries and invest a lot of time in preventive procedures and not just in curative procedures. As I told you, skill is not in, treating, but it is preventing and identifying the disease early and managing it successfully. So that is also a proper skill. Please don't be under the misconception that skill is only hand skill where you can cut a good cavity. No, skill lies even in detecting, diagnosing, and managing the patient as a whole. So to conclude, in this changing paradigm of dental caries causation and management, preventive dentistry, a virgin field to be very honest, must receive its due share of attention in management of caries, and all dentists should incorporate prevention into their routine practice. This is especially applicable for budding dentists like you all, because you're going to be the future dentists, you're going to be the future dental workforce of the nation. So if you bring about a change, definitely there's going to be change in the oral health of the entire nation. So at last, I would like to say that, we have to change our perspective with changing paradigms of dental caries. And I would like to really conclude by saying that you can't go back and change the beginning, but you can start where you are and end the change and change the ending. Meaning to say that now we cannot go back 50 years, earlier and say that, what you have done, we are going to reverse it. No, it's okay. We will make a new beginning from today. And, we're going to change the end of this whole disease process itself. So with this, I would like to thank you all for your patient listening. And I would like to acknowledge the management, dean and staff of Faculty of Dentistry, Segi University, Malaysia, for all their cooperation and, help in this webinar. Thank you very much.
Thank you, Dr. Pia. and very enlightening, and especially focus on primary prevention and new classification ICDAS, which you mentioned, like instead of DMFT using ICDAS. It's really enlightening. And there's one question Naveen sir has put, like, please give the detail of diet chart, madam. Can you send me the, like, if it is possible now, otherwise later on I'll send this
yeah, sure. I will share the form what we are using. See, there is no standard format. So what we did is we did a lot of literature search, and we 4 or 5 experts we sat down in the department. And what is required for us, for our students to do the diet analysis, we have developed a form. So I'll be more than happy to share that form with you all.
Right. Thank you. There's one question from my side, like you mentioned silver diamine, because we have not experienced silver diamine. So is it any difference or effectiveness of silver diamine and other like fluoride application? Because enlightening this light on this silver diamine.
Yes. They say that, see, actually, to be very honest, even I have not personally used silver diamine, but I have done a lot of literature search, in the prevention of caries and things like that. The main difference between silver diamine is that, and other forms of fluoride, is that silver diamine is a combination of silver, ammonia, and fluoride. Silver is antibacterial, and fluoride is an antichoriogenic and remineralizing agent, and ammonia acts as a bond between them. So when you use a silver diamine, they say that you could use this even on a cavitated caries, and then it is going to arrest the caries. So this is how this is different from other forms of fluoride, which generally is effective only on intact enamel surface where the cavitation is still not accomplished.
Okay.
So this is how it is better.
Thank you, Dr. Priyadarshini, for wonderful presentation. This is really eye-opening presentation, even for me also. And I hope your presentation will definitely give new information to my undergraduate students of my faculty. Thank you very much. It's a really worth seeing your presentation. Thank you very much.
Sir, please, felicitate with the certificate to Dr. Pradarshini, our speakers, please, sir.
Oh.
Sir, it is on the on the screen, sir.
So, Dr. Pradarshini, thank you very much. And please accept this small memento of token from this side for your wonderful presentation on this auspicious Dentist Day. Thank you very much.
Thank you, sir.
Thank you, sir. It was an honor to be associated with all of you. And thanks to Dr. Vinay. Dr. Naveen also, I have, had personal interactions. I don't know whether he remembers. We worked together as examiners back 10 years ago, I think, if I'm not wrong.
Yes, madam.
So I think,
I do remember.
thank you so much. And all the organizing team for having it organized it so wonderfully without any hitch, without any glitch. So I think... thank you very much. Thank you. And thanks to all the participants, for your patient listening on a weekend, that too, on a Saturday. So I think, thank you very much. Thank you.
Okay. Now, last, word of thanks by Dr. Gaurav. Over to you, Gaurav. Thank you.
Gaurav, your mic is muted.
Okay. Thank you so much. Thank you so much, ma'am, for your wonderful presentation. We are extremely appreciate our heartfelt thanks, especially to our respected Dean Sir, Priyadarshini ma'am, all the senior faculty members like Naveen Sir. From BBD, we have Dr. Sugandha. From Career, we have Dr. Sitanshu. And all the faculty members who have joined from KGMU, Sardar Patel, BBD, Saraswati Dental Colleges, and the Career College. Also from the Kotiwal Dental College, we extend our warm welcome. We wish you to join again back in future in such kind of programs. Thank you very much. Have a good day. Happy Dentist Day. Also, we are very thankful to our IT cell who have been with us till the last to encourage us in this kind of platforms. Thank you so much.
Thank you. Thank you.
Dr. Vinay, can I leave the